All right, hello and welcome to the webinar today on ambulance documentation. My name is Mary Sue Gardner and I'm a registered nurse on a provider outreach and education team. And I'm joined today by other members of provider outreach and education as well as medical review who are going to be helping me with the chat and the question and answer portion of today's call. The focus of today's event is on the documentation for ambulance transports and how that documentation helps to prove medical necessity. Now, coming up on October 21st, we also have an event on Medicare ambulance medical necessity. So this event's a little bit unique in that it's going to use your pre-submitted questions and scenarios to walk through examples of medical necessity. So if you haven't already, you can register for that event using the live events link that Jennifer already loaded into the chat at the start of the call. But if you joined after she loaded that, I am going to ask her to go ahead and put that into the chat again right now. So also, if you're new to WPS or new to WPS education, I want to take a minute and remind you about our YouTube platform where we post all of our educational events and encores of recorded webinars, as well as any other videos that we've developed on the service. We have a specific playlist just for ambulance. So if you were not able to join for one of our prior events, such as those that were specific to transportation, like hospital transports, we did an event on transports during the inpatient stay, specialty care, etc. I want to invite you to go to our YouTube page and check out the playlist that's specific to ambulance. You may find that you it's one of, hang on for just a second. Morgan, I think you might not be on mute. All right, perfect. So sorry about that, just a little extra noise. So anyways, Jennifer put that link to the YouTube playlist into the chat for you, and I do invite you to go out there and take a look. Again, today's focus is on the specific components of documentation and how those components should be documented to help you meet the medical necessity requirements, as well as how they are reviewed upon medical review. As we move on, in every event that we do, we show you our disclaimer. And our disclaimer basically says we prepared this as a tool for you today using the most current laws, rules, and regulations that are out on CMS's sites and the Code of Federal Regulations, et cetera, as they are today. If those change tomorrow, it's your responsibility to make sure you're following the rules that are in place tomorrow. We're going to provide any answers to any of your questions based on the laws, rules, and regulations as they stand today. But know that CMS and Medicare rules will be the final determinant of coverage. Also, you are prohibited from recording or taking screenshots of this event for profit-making purposes. Since we don't know why you would be doing that, we do ask that you stop if you are doing that. And we are recording it for you, and it will be posted to our YouTube page within 15 business days of this event, and usually sooner. On your screen, as well as in your slide deck, are some acronyms. Now, Medicare is full of acronyms, and if you've been around long enough, you know Medicare is like acronym soup. So these are just acronyms I may refer to today during the course of this webinar. If I refer to one of these acronyms and you don't know what it is, just refer back to this page or put it in the chat and one of my associates will help answer that for you. All right. My objective for today is that you learn about the documentation that's needed to really navigate Medicare ambulance coverage criteria. So in order to achieve this, we're going to talk about just some basic coverage criteria. And then we're going to go through the documentation requirements, and we're really going to give some tips for efficient documentation for you. So it's not a big review on the coverage criteria itself, but the focus is on the documentation. So let's talk briefly about the coverage criteria for ambulance, because that's going to help you understand why our emphasis is what it is on certain documentation components. So ambulance services are a transportation benefit under Medicare. There are vehicle and crew requirements that must be met, as well as a patient need for the service, meaning that transport by ambulance is the only safe way this patient can be transported, because all other means of transportation would be contraindicated to that patient's condition. So we refer to this as for Fred today, meaning Fred's condition at the time of pickup, all other means of transportation would be contraindicated for Fred's condition. So in order for a claim for ambulance services to be denied by Medicare, either in full or part as not medically reasonable and necessary, under 1862A1A of the Social Security Act, a couple criteria must be met. So that particular ambulance service would have to meet the benefit definition under 1861S7, and it would have to be a Medicare covered service. And that particular ambulance service, in full or in part, would have to be determined to be not medically reasonable and necessary for the diagnosis and treatment of their illness or injury, or to improve, the function of a malformed body member. And that's how CMS states that in, or how it's stated in the Social Security Act, so 1862A1A. So it basically says you got to have a benefit, you got to have the ambulance services that meet the benefit, but in order for us to deny it, you're not meeting all the criteria. So in general, medical necessity denials apply to claims for covered services that are not covered on a specific occasion for that particular individual. So we often express this as not for Fred today. The same service may be covered for Fred on other days and might not be covered for him today because he doesn't meet all the medical necessity requirements. So we're going to continue on and talk about medical necessity. Medical necessity requires documentation that supports that patient's condition that requires an ambulance transport, that any way other going to a hospital or going to their destination would be contraindicated because of that patient's health and well-being on that particular day. So something that could jeopardize that patient's health if they went in any other means, make their condition worse, etc. So the law refers to this as contraindicated. This is not a limitation of liability situation. This is a coverage issue defined in the patient's Medicare and You guidebook. So Medicare sends that guidebook yearly to each beneficiary or household and lets them know about the information that, what's covered when it comes to ambulance services, as well as other Medicare services. So as we continue on with medical necessity, besides supporting that the only safe and effective means of transportation for Fred today that is not contraindicated to Fred's health is via ambulance, then there's also several other requirements that make up medical necessity of an ambulance transport. And this includes proving that medical necessity of the EMT assessment. So why does it need the EMT? What does that EMT need to monitor? What does that EMT need to treat? What do they need to be looking at to make sure Fred is safe and being transferred or transported safely and effectively? Is there any kind of self-harm issues that if Fred went via some other way, he could be at a risk to himself or others? So that's also part of proving medical necessity too. It may not be a medical condition such as a fracture, to the pelvis or something like that he couldn't sit. It could be because of his mental health conditions. He could be a harm to himself or others, but we have to document that, and you have to let us know why. So if you're following along with the slide deck, this slide actually is out of order for you. And I moved it around because it made more sense when I got to developing my speaker notes. Doesn't mean that, it's disappeared. It's just one more slide down for you if you're following along with this slide deck. So continuing on with supporting medical necessity. Don't limit yourself as an EMT by not using your senses when you're doing your assessments and observations of your patient. If you do, you could miss subtle signs and symptoms, which could affect your findings and maybe lead to even incorrect treatments of your patient. It's easy to develop tunnel vision when you arrive on a scene because your sight may pull you in the wrong direction. For example, general systemic cyanosis of a patient could make you believe that the patient is experiencing severe respiratory compromise. But indeed, it could be a sign of something different, such as extreme hypothermia or even blood loss. But using your senses and documenting what your senses hear, see, taste, feel, smell, it's going to make you a more effective charter. So what the patient is telling you is just as important as what you see. So let's again briefly talk about your senses and your documentation and what I mean by these. As an EMT, use your senses again to document what you see. Your interpretation of the illness, the injury, the patient's color, the description of broken bones, etc. What's your visual observations of the scene, of the patient when you arrive at the scene and as you're treating the patient? What do you hear, such as lung sounds? Are there crackles or rails? More importantly, what is the patient and or bystanders telling you? If a patient or family member tells you something different than what you see, you may want to look at the patient again. Also, under hearing, is there things like sucking chest wounds, garbled voice, slurred speech, etc.? What do you feel? Is it warm to the touch? Are they moist to the touch? Is there profuse sweating? As you're palpating the body, looking for unusual findings or causes of pain, what are you feeling? Are there bones that feel they're out of place? Are there thready pulses? Are there lack of peripheral pulses? What do you smell? Gangrenous flesh has a distinct smell. If you've been around it, you know what it smells like. Does the patient have fruity breath? Are there chemicals? Do you smell chemicals? Are we someone that has maybe ingested or become, anoxic because of chemical exposures? Finally, taste. It's not a common practice in the medical world, and I'm not suggesting that you start tasting anything at the scene. But sometimes we get that perceived taste, whether that's good or bad. And it should be noted. So sometimes fruity breath can cause you to have a taste in your mouth. However, that fruity breath may be a sign of diabetic ketoacidosis for your patient. Again, I don't encourage anyone to go licking things. That's not what I'm saying. But we all know that there are certain smells that can cause us to experience taste perceptions. So if that happens to you at the scene, document it. Other things, in terms of bed confinement, it is helping to support the medical necessity of a transport by ambulance. You must be sure to document bed confinement if the patient happens to be bed confined. In the upcoming slides, we're going to talk about bed confinement by itself a little bit more. And then Medicare may consider patients who need ambulance transports due to oxygen dependency. So the patient must need the EMT for monitoring placement of that oxygen, not just oxygen that they've had for years. They're normally used to having a portable tank or being on a portable system and can transport in a car, with their portable system quite easily. So the physician certification statement, or the PCS, must support that the ambulance is the only safe means of transport. And this is outside of emergent transports, but the EMT's evaluation must explain why the patient needs transport in the run report. It's not supporting items that don't support, oxygen dependency for ambulance transport include things like patient requires oxygen monitoring without getting any further explanation, or patient can place the oxygen themselves without assistance, doesn't require the skills of an EMT. All right, so as we move on, this is the slide I said I moved on your slide deck that you have in hand. Documentation basics. So each ambulance trip must stand alone. So the documentation for each one-way trip must be able to stand alone all by itself. So if we were to request one of those runs, you have to be able to give us that information so that trip can stand alone and not rely on documentation from some other trip. The dispatch information must be supported, but that doesn't drive medical necessity. So what really drives medical necessity is what's happening at the scene. Remember, if your documentation does not support medical necessity, it's likely that Medicare is not going to pay the base rate or the mileage. Remember, there are no required specific forms. We just require the info to be there. And you can determine the specifics of documentation on your own. So let's look at some of the specific elements of documentation. And as I said before, we're going to talk about bed confinement all on its own. So when it comes to bed confinement, remember terms like bedridden, bed confined, stretcher patient, or required restraints do not all by themselves support medical necessity. So if that's all you document, that's not going to help prove the bed confinement to support medical necessity. The term bed confinement is not synonymous with bed rest or non-ambulatory. It's simply one element of that beneficiary's condition to consider in determining medical necessity for ambulance transports. So contractor determination will always use the contraindicated piece for medical necessity. Is transport by any other means contraindicated? So CMS indicates that a beneficiary is bed confined when they are unable to get up from a bed without assistance, unable to ambulate, unable to sit in a chair or wheelchair. So situations where Medicare may consider bed confinement When a patient has contractures that create non-ambulatory status and the patient can't sit, severe generalized weakness. So if they tried to put them into a chair or a wheelchair, they may not even be able to hold themselves up. Immobility of lower extremities and issues causing the patient to be unsafe sitting in a wheelchair. Things like if they're in a spica cast, if they have fixed hip joints or lower extremity paralysis and they aren't able to hold themselves up or sit up in a chair or a wheelchair safely. So you can always refer to the CMS internet-only manuals. And if you go to the Benefit Policy Manual, Chapter 10 on ambulance services, Section 10.2.3, you can read a little bit more about that. And I am just going to paste that right there into your chat, just so you have that. All right. So let's continue on with some of the specific elements of documentation that must be captured. And there's a lot of information here, and I'm going to go through this kind of quickly. So it is best when the patient proves the documentation information themselves. Medicare recognizes that this isn't always possible, but when you can get information from the patient, get it. Documentation from any other person, relative, bystander, even the EMT observations is allowable as well. So let's move into the things that all documentation must contain, whether it's on your run sheet or located on another form that you keep in your ambulance documentation. So patient's name, and the patient's name as it appears in the Medicare system, and the patient's Medicare beneficiary identifier, or MBI number. And so what's on their Medicare card should, and how it appears with their MBI, should all match. All right, date and time of transport. Date is important, especially if there's a transport over a midnight. So the date of pickup and the date of drop off, they could be two different dates. The time, we encourage you to document in military hours, or if you don't use military hours, make sure you're using AM and PM indicators. Point of pickup, so the address for the point of pickup. If you don't have an address and it's on the side of the road, the zip code or the cross streets or both will help you with that. Again, so if there's no zip code that exists, document the closest point of pickup, any kind of landmarks that you can give to give the closest point of pickup. Your point of drop-off, that's your facility where you're bringing the person. So that one, you need to have your street address and you need to have the 9-digit zip code associated. Mileage information. Now the mileage information, we need the loaded miles or the patient on board miles. We don't want to just see the general odometer reading from when you left the house until you picked up the patient and got to whatever drop-off point. So your odometer mileage or your loaded mileage is what we're looking for. If odometer reading isn't available, it's okay to give us electronic mapping software or just use trip odometer, miles. Provide us a brief explanation of why you're not using your odometer mileage and using something alternative like Google Maps. If your odometer's not working, it's not working. Just let us know, and here's what the mileage is from point A to point B. All right, name and credentials of the EMTs treating the patient. So You have to have legible signatures, and if they're not legible, it's okay to have an illegible signature, but it has to be above a printed name, so long as we can identify who it is. And then we need to know what your credentials are, your state licensing credentials. Are you an EMTB? Are you an EMT paramedic, et cetera? So we need to have that in your signatures as well. We're going to look for, and we expect that you are documenting the medical necessity of the transport. So why, a few things I want you to think about. Why does it need you as an EMT? Or why does it need your EMT? What is your experience training? What requires you, your licensures, your expertise to transport that patient on that day? What do you have to do for the patient? This is your opportunity as an EMT to sell yourself in your documentation by what you are doing, what you are monitoring for, what you are observing, what you are treating, etc. Why transportation by any other means would be contraindicated, which moves us then kind of into the observation and assessments of what you do. So your patient complaints. What was the reason for their dispatch? On scene, what is it that the patient or the caregiver or the bystander, et cetera, are saying? Why does this patient need an ambulance and need you today? So you're going to start observing the scene. You're going to start observing the patient. You're going to start using your senses. What do I see? What do I smell? What do I feel? What do I hear, et cetera? And you're going to start documenting those things in your overall assessment. And what kind of assessments are you doing? What kind of treatment do you need to provide? Relevant history and physical of their present illness, or relevant HPI, history of present illness. So what's going on today with them that requires you, your expertise? Again, what are any of those observations by the bystander that happened just before the illness, injury, accident that they can tell you about? The method of transportation needs to be documented. So is this a BLS run, an ALS run, a specialty care transport run, et cetera? Treatment. Again, we've said this a lot. What are you monitoring? Are you adjusting oxygen? What kind of interventions? Is there IVs? Are there medications that need to be administered en route, et cetera? And then we move in. What's the patient's condition at and during transport? So at the time of the scene and during transport, are conditions improving? Is the patient's vital signs getting worse? Is the patient's stability declining? If there's no change, note that there's no change. Again, the point of drop-off information. So who is the staff at the receiving facility that's taking the patient, and the condition at the time that you transferred care to the person at the receiving facility. If there is a dispatch report or method for the level of transport, the method of complaint, the 911 or other call, what is that? And then you're going to have basic like rig identifier information, who you are, what rig you're associated with. And then we move on to things like signatures. Patient signature needs to be present if you can get it. Try to get a legible or identifiable, but that doesn't often occur. You should try to get that before billing. So it may not be necessary, or it may not be reasonable to get it at the time of transport based on that patient sign symptoms, being under duress, things like that. You can also, if the patient is unable to sign, a signature could come from the representative or a family member, but you would want to get that person's information, who they are, what relationship to the patient they are, etc. All right, and then crew members can sign when no one else is available for that patient, and the documentation needs to indicate why that patient wasn't able to sign, and the crew member signed for them. If no one else was available, and then you have to provide your name and address of the company and a legible signature of the crew member. And then finally, things, if you know them, like is the patient on any medications? Do they have any allergies? Family and social history, name and relationship of caller. If you issue an ABN, you should keep that ABN. If you have a physician certification, which we're going to talk to, keep that. And any information like a treating or transferring facility records, have that information available as well. So that was a lot on all the different components, but I want to spend a few minutes and talk about physician certification statements all on their own. So the physician certification statement or order is when that physician, that treating physician, is attesting to why the transport by ambulance is medically necessary. And PSCs are for non-emergent ambulance services that are either unscheduled or scheduled and done on a repetitive basis. There's no specific form. However, WPS does have a sample physician certification form that we encourage providers to take a look at and consider modifying it into your own or something similar. Remember, the physician certification statement alone does not make a transport medically necessary. It's just one component. The transport must continue to be medically necessary or for FRED today, meaning any other means of transportation would be contraindicated. Now, I do have a link in the slide deck to go to our physician certification statement. In the interest of time, I'm not going to link out to that, but if you go to WPS GHA and just type in physician certification statement in the search bar, you're going to come up with it. Or if you have the slide deck, you can go ahead and use that link. All right. So next, a little bit about the requirements on the physician certification statement. As I stated, when we looked at the prior slide, when you're providing transportations that are scheduled or non-scheduled and non-emergent that require a PCS, if it is a non-emergent scheduled on a repetitive basis, the order or physician certification statement cannot be dated more than 60 days before the transports are to start, and they have to be done by the physician. When unscheduled and on a non-repetitive basis, the physician certification statement is required if the patient is a resident of a facility and under the care of a physician. That order or PCS can be obtained within 48 hours of that transport occurring. So you have up to 48 hours after the transport occurs that you can still get it. If you're not able to obtain it from the physician, you may obtain it from a non-physician practitioner, or you may be able to use a non-physician certification statement, which we're going to discuss in a little bit as well. So remember, if the patient is coming from home or they're resident and is not under the care of a physician, a PCS is not required. So let's move on to non-physician certification statement, because I just want you to, be aware of the differences. There are certification statements signed by someone other than the physician when they're allowable, such as non-scheduled or even scheduled non-emergent transports that are not repetitive. So basically like a one-time transport. That's not a repetitive transport. So you can have someone other than the physician sign when the physician is not available. And that is allowable. And the information is in the 42 Code of Federal Regulations 410.40. And you're going to want to refer back to that and make sure you're following those rules correctly. And back on this slide, I actually provide you a link to that. So again, non-physician certification statements can be signed by someone other when you can't get a physician certification statement and it's not a repetitive transport. It's a non-repetitive, scheduled or unscheduled, non-emergent transport. All right, which kind of is what I said here. So situations that don't require a physician certification, emergent transports. We don't need a physician certification. Anytime a patient is under duress, you don't need a physician certification statement. And that usually goes hand in hand with your emergent transport. Or when a patient is like coming from their home, they're not under the direct care of a physician. And then again, just to kind of touch base, when you're not able to obtain that physician certification statement, what do you do? So if it is scheduled, repetitive, non-emergent transports, you have to have a physician certification statement. So you must obtain that. And you got to keep trying to obtain it and give your best effort and document every time that you have tried to contact that physician and obtain that certification statement. So non-scheduled, non-repetitive, again, are one time. You have up to 48 hours after. When a physician isn't available for those non-scheduled, non-repetitive, or those one-time transports, and the 48-hour passes, you can't get the physician, and you can't get anyone else to sign, like a non-physician, you have up to 21 days after the initial attempt, and you got to document all your attempts and the method. We do encourage you, and it is part of the regulations, that you send some sort of certified letter so you have proof of your mailing, or any other means that provides proof of mailing. If you send via fax, make sure you are keeping your fax transmissions. If you are emailing, make sure you are saving all those emails. And if you're making phone calls, make sure you are documenting date, time, any messages left, who they were left with, etc., to support that. All right, and then mileage. Again, we've already kind of touched on this, but when documenting mileage, make sure you're documenting the loaded miles, so the amount of miles the patient was on board. Again, use the odometer reading. If you don't have an odometer, you can use mapping software, or if it's just not working. Payable mileage is to the closest appropriate facility that has bed, staff, and equipment available to treat that patient. So what we're looking for in closest appropriate facility is not necessarily the closest in mileage. It is the closest facility that has the means available to treat your patient. If you're bypassing a facility within your locality, you know, and well beyond, 5 miles of your locality, then tell us why. If there's no beds available, if they're on staff, or they have staffing issues, if the facility's on diversion, if they don't have anyone available to treat cardiac conditions that day, or all cardiac conditions are going to XYZ hospital, which is outside your normal locality, then you need to let us know that. So then that can be considered unpayable if it's the appropriate facility that's closest. All right, and finally, the review. So everything that we talked about goes into our medical reviews. When we pull apart your documentation, A, we're looking for medical necessity. Was this the only safe way Fred could transport today? And then we pull apart all the rest of the documentation and make sure you meet all the other coverage criteria. Like if you provided an ALS, did you meet all the requirements for assessments, interventions, procedures that have to be done? Do we have the signatures and credentials of those people that treated the patient, the EMTs? Do we have the signature of the beneficiary or family member or someone that signed on the beneficiary's behalf? Do we know the origin, the destination, the loaded miles? And then if there's something beyond your locality and you need to go to a facility beyond your locality, is this the closest appropriate facility to treat your patient that's in your ambulance with the conditions that they are experiencing right now? And it's not based on where that patient wants to go. It's based on what that patient needs and who is the closest appropriate facility to take care of that. Now, if there's two hospitals and they're both relatively within the same amount of distance and they both have the services to treat the patient and they always go to facility X, and facility X and facility Y are about the same amount of distance, and they say, hey, I want to go to X, then take them to X. It's still within the closest appropriate facility. All right, and that is going to take us to the end of the formal presentation. And I know that was a lot, and I know I went quick, but I want to provide a little bit of time to go over some of the questions that I see have come into the chat. And the first one that I'm seeing right off the bat is mileage reported in whole miles or fractional mileage, tenth of a mile. If you have it down to fractional mileage, you can report it in fractional mileage. If your odometer readings do not give you fractional mileage, then you would report in whole mileage. Let's see. And then, promote to highlight action. All right, I'm not seeing, and Jennifer, were there any other questions that have come in that we did not touch on? I was scrolling through one.
You just got one. Oh, wait, I'm sorry. Never mind. No, I don't see any other ones.
So, and then Hannah from Medical Review was just helping me out here, and she said, when the mileage is below 100 miles, you need to report in fractional miles. If it's above 100, it's reported in whole miles. And then refer to the Internet Only Manual, 104, Chapter 15, Section 30.1.2 on that mileage component and documenting those miles. So thank you, Hannah. And let's see, I'm scrolling back and forth, and Jennifer didn't see anything either. So in the interest of time, I'm going to proceed on. On behalf of myself and Jennifer, as well as our medical review department, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.